right, I want to welcome everybody. I'm Mark Crosley. I'm an attorney here in Allentown with Shoreline Injury Law and the current president of the Lehigh Valley Consortium of Professional Organizations. And I want to welcome everybody here to Direct Primary Care Explained, value for you and your business. Tonight's panelists here, we have Dr. Kimberly Legg-Korba with Green Hills Direct Family Care, Dr. Charmaine Wheeler with DO and with CCC Health, and we have Chris Van Buren, a partner with Employee Benefits at KMRD Partners. Just a little bit about the LVPCO. It's an interdisciplinary organization that aims to serve professionals throughout the Lehigh Valley to help foster networking opportunities. Our mission is to provide members of each organization with the means to expand their professional network. We share in promoting each other's organization's events and industry news. We encourage and foster the exchange of ideas and information relative to business. We engage in social community activities with members of different associations to further our cooperative efforts and knowledge of each association's business strengths. Like most member organizations, we rely heavily on sponsorships. I wanted to thank today's banner sponsors, Buddy Lesavoy of Lesavoy Boots and Sites, and Bob Rust of Rust Law Offices. Thank you both for all your support. Like I said, we have our panelists here today, and without further ado, we'll get started with our discussion. So, the floor is yours. Thank you.
Thank you. So really appreciate this opportunity to speak about direct primary care. So I am going to start with where we are today. So the problem with traditional health insurance. The first, even though 92% of Americans have health insurance coverage in 2023, it's really almost effectively uninsured because they can't afford it, and its lack of access, and that's mainly because of high deductibles and out-of-pocket expenses. Those two things. So access is very limited, long waits, rush visits, endless testing and referrals, and surprise bills. The U.S. healthcare quality just dropped basically that's a Gallup poll that was 24-year low with this going on. And then in this study, so as we see, our quality keeps going down, and in 2023, premiums rose 7%, 2024, another 6%, 2025, 5.8%. So we're continuing to pay more, and employee care and satisfaction continue to decline. So in our view, DPC really is the solution that your business needs for all of those reasons. It's a membership-based model where patients pay a flat monthly fee for unlimited primary care. No insurance, no co-pays, no surprise bills. So the whole DPC model is meant to be like car insurance. You pay, you have health insurance, but it covers major things, but not routine care. Like you cover accidents, but not oil changes. DPC, the reason DPC is so cool is your employees, they would really have access to that same day or next day appointments, 24/7 direct access to their doctor. This is almost like having a doctor in your family that you can text and call. Phone, text, email. It really uses today's technology to have your doctor in your fingertips. Medications, dispensing at wholesale prices, discounted labs, imaging, and as a doctor, one of the things that's very gratifying is the long visits that are personalized, where you get to really look at the whole patient as one individual. And you really get the chance to use the reason you went to medical school, that knowledge, to be able to take that whole history to figure out what's going on. And all really for that monthly membership fee. So what this means specifically for an individual business is it reduces your overall healthcare spending, because instead of when your employee would call and they can't get into their doctor, they would often go to an urgent care or to something else. That drives healthcare costs to be higher. This one, they have access to your doctor. Maybe a text would have solved the issue, not an urgent care cost. Lower insurance premiums because you'll only need to cover the major care. decreased absenteeism because they actually got the answer early instead of got sicker and sicker to get the care. Increased productivity, boost retention by offering a meaningful, valuable benefit, and improve overall satisfaction, loyalty for your employees. So DPC increases quality at decreased cost. Very rarely is there a business model where you can increase quality and decrease cost at the same time. Real results. So DPC, since 2017 to 2021, grew 241%. And currently today in the United States, over 20,000 of the 465,000 primary care doctors use DPC. DPC practices serve, and the reason is so personalized because of the membership model. The patient panel an average doctor carries is 400 to 600, opposed to 2,500 or more. And today, employers, 4,000 plus employers use this as an employee benefit. And 91% of adults aged 25 to 35, and this is just for as an when you look at your employees, adults aged 25 to 34 and their parents, they would, if this was offered by their employer, they would choose this model.
Shamini covered a lot of it, so I only have a few slides here. I provided some links to some raw data if any of you are really interested in the hardcore numbers. There have been studies that have been done on how it lowers downstream costs for employer groups. The model's been out there long enough now that they've been able to gather and analyze the data. And again, you're providing a better service to the patient, so you're going to have better outcomes because we're spending more time with them. We're keeping them out of the ER, out of urgent care. We can lower specialist visits. I'll pick up the phone and call the specialist while the patient's in the room, or text them. And a lot of times the specialists, they're just as busy. They're as busy as we are. We could save them an appointment or an unnecessary visit if we can collaborate over the phone. We used to do that a long time ago. That doesn't happen as much anymore. So management of chronic diseases, like those listed up there, the patients do better. And it just makes sense. More time with the patients and better time management and attention. These things are going to, these chronic diseases, the patients are going to do better. This link is to a big actuarial study that was done in 2021. It's 98 pages long. I was interviewed for it, and some of the other older DPC doctors who have been, I hate to call myself older, who have been doing this for almost a decade, we were all interviewed for this. There's some interesting data in there. We didn't feel that the cost savings really reflected how, there was cost savings. We felt that it should have been higher. So we're not sure who they collected their data from, but they interviewed all of us. Nevertheless, the DPC practices reported reductions in the per member per month costs. So again, just kind of logical. The savings included the ER visits, reduced inpatient expenses, lower per member per month costs, and decreased home health and ambulance expenditures. If the patients can get us on the phone, if the patients can get us on the phone, we can cut down on those ER visits and rehospitalizations, which we all know the hospitals hate because of Medicare. We try to keep them out of the hospital. I've done house calls for my elderly patients. I think most of the direct primary care doctors have done a house call or two. So just kind of like going back to Marcus Welby, MD. The old-fashioned way. Now, what's important to know is we do not replace the need for health insurance. We only provide primary care. This is our scope of our training. Anything outside of our scope has to see the specialist or for that reason, they need a wraparound plan, some kind of major insurance. My dad still talks about the major medicals back in the 80s, the major medical plans, which were big wraparound plans. Somebody's nodding their head in the back. And you could buy riders. You could buy a vaccine rider. You could buy a rider for diabetes. And it's just like Shamini said, like your homeowner's policy. You're going to buy personal or valuable property rider if you have like expensive artwork at home. You could tailor the major medical to what you needed. Those don't really exist anymore. It would be nice if they came back. Nevertheless, they need some kind of wraparound. We are not a replacement for insurance, nor are we an insurance product. So in summary, these are my logo and my motto in my office has always been attention, access, and affordability, the 3 A's, the triple aim. That's our triple aim. We know there's another triple aim out there. So the attention, the prolonged visits. When patients come to me, I always ask them how they found me and why they're seeking out DPC. And I've been doing it this is my 11th year. I was the first one in the Lehigh Valley to open a direct primary care practice. And one of the common reasons is patients don't like the short visits and they can't discuss more than one issue at a visit. And that's limited by the insurance companies. So, last week I had an hour-and-a-half visit. I did a physical, complete physical, a GYN exam, including a pap smear, drew blood work, addressed chronic issues, and took care of one acute issue, all in one visit. They would have been told to come back for 5 visits in the existing system. That's more time out of work for them, other co-pays, then those charges go to their deductible. It's ridiculous that we can't address all of those things in one visit. Access, same day, next day appointments for acute care, stay out of the ER, stay out of urgent care, and unrestricted amount of visits with the monthly membership. The affordability, my cell phone costs more than a DPC membership. Our cable bill costs a lot more than a DPC membership. So it's very affordable. I've seen the copays. The patients tell me what their copays are. They're going up. So a lot of copays are almost equivalent to what we're charging, especially in the ER and the urgent care. Those copays are ridiculous. And then again, those visits get charged to deductible if they have a high deductible health plan. 75% of my patients have insurance, 25% don't. And I'd say 10% of that 25% choose not to have insurance and want to pay cash for everything. So they will actually go out and seek cash prices even if they need an appendectomy. It's still cheaper for them than paying $24,000 a year for an exchange plan with a high deductible. That's all I have. This is Shamini's last slide here.
That's good. Go ahead. Basically, it really is a win-win. It's better for everybody, better for the employees, for your business, and it's a benefit, really stands out, that really can be used as a recruitment tool for business.
So as during the introductions, as mentioned, I'm Chris Van Buren. I'm not a doctor, so I'm not nearly as smart as the 2 doctors that just spoke to you. I am with an employee benefits and business insurance firm. And so one of the reasons I was very excited to talk about this is, yes, I help companies put together their employee benefits plans, but I'm particularly passionate about direct primary care. I can even tell some personal stories. So because I got to know about direct primary care through the work that I do, probably got to know about it 5 or 6 years ago. When my kids they aged out of their pediatrician practice, so my kids are now 22 and 23. When they were 18, they aged out. And they know that I use my friend as my primary care physician. So I don't personally use direct primary care, but that's because he kind of treats me like direct primary care doctors treat their patients. But they said, that's not where I want to go. And so we connected them to one of the primary care practices that we know, just a little closer to our home. And it's fantastic. I mean, and our kids would not have any other way that they would do it. I can just give a few examples. You know, away on vacation in Michigan, and our daughter fell off one of the tubing, the boat dragging a tube, and her ear hurt. And we were able to have a video call and a text, and it absolutely saved driving who knows how long to get to an emergency room or an urgent care. And she was able to deal with it through that way, and then say, hey, on Monday when you get home, come on in. Other times, they went away to college, and it was the perfect way for them to keep their doctor, go hours away from where the doctor is, and they kept their doctor. There were things that they needed to do in person over breaks or over summer. But other than that, we sometimes don't even get calls from them, and they were able to just work with their physician. So anyway, it's not what I do as a profession, but we do help integrate it into plans. And like I said, I'm personally passionate about it because I've seen it with my children.
Can I interject something?
Yeah.
So with all the colleges around here, I get quite a few college students who come and, Muhlenberg, they sign up for the school year, and their parents love the fact that they have their own personal physician and they're not going to this student health center. My daughter goes to University of Arizona. She has a DPC doctor in Tucson. My son has a DPC doctor in Philadelphia, both of them.
Yeah, That's great. So as I have up here, from me thinking of this when I'm talking to employers, there's really kind of two different reasons to implement direct primary care as an employee benefit. One is for the plan, and when I say for the plan, for the health plan. And so that's to lower costs and have the plan have a better financial performance. And some of those things that we've already talked about is in direct primary care, yes, it's only primary care. And as mentioned, it's not going to cover everything. It's not going to cover surgeries or specialists. But a lot more care gets taken care of in a lower cost setting. Yes, specialists are still needed, but there's a lot of things that can be taken care of at the direct primary care setting, and it's a much lower cost setting. In addition to the amount of care and the relationship that ends up avoiding a lot of downstream chronic conditions or more severe conditions. So it's going to help the plan. But when I'm talking to employers, I really talk about the second part, benefiting the people, the employees. That's going to happen a lot faster, and it's going to have a lot, I have found with my clients, that it's going to have a lot faster and immediate effect, in that this is something that when it gets put in, maybe it might not happen on day one, but it can start happening by month 3, sometimes by month 1, but it'll definitely happen within the first year, that employees really have a great experience. Look, I'm in the health insurance business. I know that there's a lot of complaints that have to do with health insurance. We get them when the employees or the employer call us, and we know that that employers often hear complaints about it. When this becomes part of the employee benefits, it's not complaints. And it's typically employees coming in, and the reason it grows over time in terms of people using it is because employees hear word of mouth. This is what I've been doing, this is great, and they'll talk about some of their great experiences. And so that's why when I talk about it with employers, it's the plan and the people, but the people benefiting from it is going to come first. We've actually, how it benefits the health plan, I talked a little bit about this already. Better chronic disease management, the predictability when you're paying for the membership for the employees to go there, that predictability of cost is better than some of the more variable costs that'll pop up. So what I end up getting from employers is, okay, so how can we use this with our employee benefits? And there's a number of ways, and some of this has to do with what size company you are. Some of it has to do with what you're already providing. And so I'm going to kind of go from the simplest to the more complex. And the most simple is I know there's still employers out there that say, hey, we don't provide health insurance, but I wouldn't mind providing something. But like even the least expensive health insurance is just too much for what we're doing. And so just providing a membership to this, the education has to be there. This is not insurance, as Dr. Korba said. The employees have to understand that. But really, I mean, it's tough to come up with a percentage, but this is going to cover a majority of what they need. If not in any given year, maybe it covers everything they need for healthier people. But that's the simplest way to integrate it. The next thing that I'm going to mention, this may not be that well known, an ICHRA. The industry nicknames it an ICHRA, just to pronounce it that way. It's an individual coverage health reimbursement arrangement. And people may not know about this. This actually, the ICHRA specifically came into law about 5 years ago. And an ICHRA is a way to reimburse employees with pre-tax dollars for insurance plans they buy. So that they're buying they're called individual plans, but whether it's a family, spouse coverage, or just individual. And so that's another way to do it is that, okay, I'm going to give some pre-tax dollars for them to go buy. And even if that's $100 a month, that's $100 more dollars, then it doesn't have to be the full cost of the coverage. The employer can choose what they're going to give for the pre-tax coverage and then maybe pair that up with a direct primary care membership.
And that's deductible to the employer? And it's tax-free to the employee, correct?
Correct, yep.
That was an executive order, I think, in 2018, right?
For the ICHRA?
Yep.
The ICHRA was more 2020, but there was something called a QSARA,
Okay.
just not to get too technical. But yes, that happened back in the later teens, 2020s, that this, so a lot of employers don't know about these yet. And one of the reasons is the individual market, especially in Pennsylvania, was not very strong after the Affordable Care Act kicked in 2014. A number of carriers left, but more carriers are coming back into the individual market. So we are seeing this is more of a play for people to do. And then what I'm calling moderately simple is people have group health insurance. They're offering it at their, as an employer, they're offering it. And I think this is closest to what you were saying, that people will have a wraparound plan. And so this may allow an employer to maybe have sort of a lower cost, higher deductible plan, and then put DPC in with that. Or they can put DPC in and then have a range of plans that people can buy. And having the DPC allows somebody to be more comfortable buying the lower cost, higher out-of-pocket health insurance plans. So the next three are going to get a little bit more complex, and this is going to typically be when employers are going to be a little bigger. Historically, this means 100 employees and more, but because health insurance has become so expensive and difficult to manage, we've even seen self-insurance coming down to 50 employees. Before our company got bought, we were 30 employees and we had a self-funded plan. But it's not for the faint of heart to drop fully insured and go self-funded. But if people can go self-funded on their medical insurance, what we're seeing is an option is put in for people to go to one or more DPCs, depending on how large the company is, how many locations they have. We might need to find multiple DPC offices to allow the employees to have options of where they go. And it's totally optional. They can sign up for it. Typically, I've seen the plan pays 100% of the DPC membership, because the plan knows that the plan is going to financially be better off if it pays. It would my clients' plans would love it if all of their employees joined and they had to pay the membership, because they know that them paying the claims in their self-funded plan, it's going to go down if everybody would join. So the next slightly more complex is people have put in self-insured plans, and they will say, if you sign up for DPC, there's a plan over here, and the deductibles might be 0 or really low for hospital care, for imaging, for that type of thing. They might make a plan where if you do DPC, you're going to be in this plan that has much lower out-of-pocket costs. Imaging might be $100 instead of $300. Outpatient surgeries might be 0 cost, or maybe it's half the deductible. That this plan over here, if you joined that plan, things without a DPC plan, costs, out-of-pocket costs would be higher. I have not put in one of these plans, but I know some colleagues around the country that the most complex is they've said it's mandatory that you go to the this plan has a DPC or multiple DPCs, and it's mandatory if you're going to be in our health plan that you go to. I haven't put in one of those, but to me that's sort of the most complex, more pure of the whole arrangements. So,
Chris, why do you say what makes a mandatory DPC?
I guess I shouldn't say more complex, it's the more extreme, I think is what I should be saying, the more extreme version of how you do this. They've all gotten complex once you've gotten to self-funding. Making 2 different plans and tiered plans is complex. Making it mandatory is just more extreme. But thanks for the question. Yeah.
It was mentioned several times that major medical or someone wraparound plans. Is the insurance industry not coming around? They're developing these wraparound plans that would be made into a DPC plan? Are there decent ones out there?
So if everyone, just in case anyone didn't hear, the mention of wraparound plans, the question was, is the insurance industry creating some products and plans that serve well to wrap around somebody going to a DPC? The quick answer is no. They're not doing things specific to, hey, if you had DPC, this would be a plan. And using the term wraparound, I think, is more just saying, hey, you need insurance.
Can I interject?
Yeah.
Oh, sorry.
No, go ahead.
There's actually a provision in the Affordable Care Act, I think it's 101.4, that allows for a wraparound plan to be coupled, and they actually mention direct primary care in the Affordable Care Act, but no company has done it.
So if it's a couple of them, I would think that would be a lower premium plan.
You would think, right? You would think.
The market's been driving, but I think lower cost plan, say for longer term,
Right, I mean, the purists in DPC feel like primary care shouldn't be insurable at all. And like Shamini said, it's like your homeowners doesn't pay for your toilet to be unplugged, the plumber to show up, and your car insurance doesn't pay for your tire rotations and your oil changes. That's what primary care is. So there's arguments out there that primary care shouldn't even be insured. It should be, it's affordable enough. It should be affordable enough. We demonstrate that it is, that it shouldn't even be part of a major health insurance plan. And that drives up the costs. And it's resulted in primary care pretty much being decimated as a specialty.
And just to, two things here, just to go off of that, the primary care really has been, and that is one of the main reasons for our society being more of an ill society, because the primary care that takes care of chronic is not happening. And when you don't have primary care insured, it actually puts a little bit of the burden of that being healthy also on the individual, which drives costs down too, because they also have an incentive to maybe not have that, cheesecake after every meal, but go out for a walk instead, because there is that out-of-pocket cost that's associated with it. So having some personal responsibility and saying that I want to be better, and so like for a lot of my patients who have been on say diabetic medicine or something, they'll come in, like insurance will cover a hemoglobin A1C of every 6 months or every year. A lot of our patients will actually, it's I forget the number, but it's a couple of dollars for hemoglobin A1C. They'll do it every 3 months because they're actively working and engaging in changing that lifestyle to drive down their blood sugars. So that benefit of having that inflammatory situation of having a high sugar go down affects your heart health, to your nervous system, to kidneys, to everything else. So the long-term projected benefit of costs decreasing is exponential. And then my second thing was about there isn't a wraparound plan, but a lot of our patients do use what we call share plans, and the share plans are basically, they give a lot of freedom to the individual to decide what they want to do with their health care. And some of the share plans are mirrored with the DPC if they get it. And so whatever they pay for the membership for their DPC is deductible for their share plan deductible.
Just to expand on the relationship change with direct care, when we're taking payment directly from the patient, whether it's the patient paying us directly or the patient being given the money by the employer or the employer paying, it changes the scope of the relationship between us and the patient. Like Shamini said, we are obligated and responsible to provide a good service, and the patients are also have more responsibility and are more engaged. It really changes their perspective on things. So, and it results in better outcomes. So it's been refreshing, actually, after practicing for half of my career with insurance and then switching to this, how it changed the interactions between the doctor and the patient. Yes.
2 questions. So, you surcharge for smokers that are...
No we do not rate on pre-existing condition. No, patients come in, do a meet and greet for free. They look over the patient agreement. I don't ask them what their medical problems are until they sign the agreement. Then we go through their medical history. They know that I can only practice in my scope of care if they have a history of cancer, if they have a history of some other chronic disease that requires specialists. They know that they still have to see those specialists, but I'm there for their primary care and to help coordinate. There's been a lot of coordination of care since the pandemic, a lot more coordination of care going on.
My second question is, why is it that the two of you are the only two DPCs?
So I want to...
Mike Carnathan's here from
There's one
Bethlehem.
right there. He is in Bethlehem. He is, yes.
Well, because we have two behemoth hospital systems dominating the Lehigh Valley, no offense to either one, but there's restrictive covenants. Doctors can't leave and do this because they can't practice within a certain, after, I know the law changed, but not much. So that's one thing. And then running the small businesses, my medical students who love rotating in our offices say running the business is a fear factor. running a small business. And I tell them it's really, if you get a good accountant and a good lawyer, it's really not that hard.
It really is. But I think we are so used to having an insurance card that covers everything. And what it effectively does, it increases cost of care because it covers everything instead of covering what needs to be covered. And so even like for myself, it was a safety net to have that card, even though maybe I didn't use it at all, but I have insurance, I have healthcare insurance. So the same thing from a physician perspective, it's hard to leave what you know, and you just get this, you have that security, job security, you get that, and then all of a sudden, are people really gonna sign up for a membership just to see me? Like, is that really gonna be, our practice is only 2 years old, and it's grown tremendously, and 99% of our growth has all been word of mouth. And I think when you say it, I think insurance is reluctant to develop wraparound plans because the profitability in the current model, the more it's too much. So in my opinion, I think that there's a reluctance, and only way that reluctance will go away if the patients say, hey, this is what I want, and get that. There's a huge reluctance for it.
And patients, in the 10 years I've been doing this, they're becoming, I was talking to somebody, one of the members at the bar earlier. In the decade since I started this, patients are becoming consumers of their health care. It's been refreshing. 10 years ago, they really didn't know what their insurance plan covered, what it didn't cover, what their deductible was, what a deductible was to begin with. And now they know. So they're starting to use their heads a little bit more with how they consume healthcare, how it's paid for, what it costs. And they're taking a hard look at some of the value that they're getting for how much insurance costs. It's ridiculous how much health insurance costs. It's almost embarrassing for me as a physician to know that, the service that I provide is or that we all provide as licensed physicians is costing this much money. It's been grassroots. Yeah, they're captive. Well, we mentor each other. We do a lot of mentoring each other. There's a lot of channels and support groups and lectures and conferences and free advice, and we're always on social media running things by each other across the country. It's been somebody's gonna have to write a book about this. No, not by I followed Josh.
But your practice.
I was the first one, yeah. And it was scary. I was scared to death. I put a bomb in the middle of a very profitable practice that Lehigh Valley wanted to buy, and I did not want to sell my practice. I didn't want to sell to anybody. I hung that shingle in 2003 with 0 patients and put our house up as collateral. My husband, thank God, went along with it. And I took insurance then, but I built it up over time, and I was rating #1 in the stupid quality measures that we all know don't make a difference for 4 years in a row. Over Lehigh Valley's employed physicians, I was rating #1 as an independent. And they were squeezing me. They wanted to buy me, and I was not, because I knew they were going to take me out of that practice and move me to a less profitable practice to help them turn around, and I would never see my patients again. And that's not why I opened that practice. That's not why we took the financial risk to open that practice as a family, and I wasn't going to do it. So I told my husband, I'm going to put a bomb in the middle of my practice. And he said, what? I said, I'm going to try this thing called direct primary care, and he was like, oh, okay. So it was a big gamble. It may not have worked. I didn't know what was going to happen. But 10% of my patients followed me, which is exactly what my mentors told me would follow, and it's been working. But it was scary, and there was a lot of education I had to do and a lot of advertising in the area because nobody knew what it was. In fact, there's a Rotarian here from the Emmaus Rotary Club who remembers me talking to them 10 years ago when I first opened. That's what I did. I went around, but I was the only one. It was very lonely. But I had a lot of people supporting me still, but it was scary.
3 years ago, my husband and I went to Kim's office and we sat down and we talked about this, and walking out of there, I wasn't sure even then if this, like, could this really work? You know, is this membership, do people really want that? And so for me, in this whole personal journey, what I realized is there's a lot of problems in healthcare, and we can talk about this financial thing, this and this and this, but really what matters is that doctor-patient relationship, and if we restore that, everything in healthcare will self-fix itself if we just give time between that relationship to do what it needs to do. And this, in the purest sense, that's what DPC does. It just restores that relationship. It literally separates the relationship from the business. The membership allows the business to run in a separate line, and every time you see your patient, it's not about collecting a copay, it's not about ordering a test, it's not about that. It's the
your quality measures,
it's not about, you know, every diagnostic code gets another billing code. It's none of that. So it's just, it takes that and it just puts that in the central wheel, the relationship. Yes. So, so the movement is bigger than the three of us in this room. There's doctors across the country who want to do what they went to medical school to do, which is to take care of patients the way that they think is best in that bonds of that relationship. And so in DC, it's called House Call on the Mall, or Doc Day, and it's a lobbying day to help get things through to
other legislative
items to pretty much increase patient choice. And one of the big ones, the HR 1, do you want to talk about HR 1? That passed, it has a stipulation for HSA.
It hasn't really, it was put into the budget bill.
But there's two other bills right now in the House and a mirror bill in the Senate by Smucker and
There's some deficiencies, though, in the bill that we're not too happy about.
Right.
And Smucker, who's one of our state representatives, and I called I'm the chairperson for NFIB's Leadership Council for 2 years, so we're very active with a lot of this legislation. They've been very helpful, NFIB. I called Smucker's office. They put a cap on how much HSAs can reimburse or can cover indirect primary care fees. It's the first medical service, qualified medical service, to be capped. And HSAs are patients' money. That's your money. That's our money. So I am a purist as far as there should be no caps. The model will not work if we charge too much. It won't work. The offices will close, so why cap it? Well, we all know who's wanting to cap it, because now we're a threat. And there were some other stupid provisions put in there. And so the Senate bill, it isn't as restrictive, and that's Senator Cassidy. But it's our state representative, Smucker, who put the restrictions in. Somebody's in his pocket. And one of the other ones is administration of IV drugs in the primary care office. Now, I don't know how many primary care doctors are administering IV drugs in the office, but I know what specialists do. And I know that it costs less if they do it in the office than in the hospital. There's no facility fee, blah, 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 blah. So somebody's losing out on money if the rheumatologists and the neurologists are starting to do infusions in the office, because the specialists are now starting to do direct care. That has taken off faster than primary care did out of the gate. So there's a whole alliance now to direct specialty care across the country.
And the model is growing so amazing that there's all kinds of innovative business models across the country, in that there's even big corporations like, gas station chains that are seeking out direct primary care, that they are like companies, huge companies, national companies that are saying, you know what, we want to offer DPC as an option to our employees. And they're trying, we get calls and asking, hey, because they're looking for DPC practices around area that are national organizations, and they are willing to pay membership on top of the benefit plan they already do. And it's because they increase all of those benefits that he talked about, employee retention, to bet less that it costs them. So I do think this model is here to stay, whether insurance gets on board and does wraparound plans or not. I think it's going to be a fight because they're going to lose money.
Well, and the employers are getting hit the hardest with the costs.
Michael, do you want to come up here and talk?
Yeah.
No, yes, come here. He's a DPC doc, come on.
Yeah.
But I wanted to talk about growth and how they're going to grow. The gentleman asked that question. I'll tell you what, I teach residents for St. Luke's, and I have interns who've already been getting into contracts by St. Luke's. So when you're coming out of medical school, 6 figures in debt, you sign a contract saying you're going to make 6 figures a year, it's hard to turn that down and walk away from it. So that's one reason why it's not growing in our area. But the way it's going to grow, not just in our area and across the country, is working with business owners like some of you in this room. I work with about 10 businesses in Lehigh Valley, 2 of which are pretty big. But one that I started out with a few years ago, we have about 80 of their employees. And time again, they say at their annual 360 review, the one consistent thing that all employees like is my practice. I'm bugged out of one nurse, and every employee puts that on, every single time. So when those sorts of options are out there for not just students, residents, and now doctors who are stuck in the system seeing, wow, all these businesses would pay me to take care of their employees, they're going to jump on board. We need more people to understand what this is and really buy into it, because it really does work. That same business, in that first year, we saved them a bundle of money on just ERs. Their ER business went down dramatically the second they joined that practice. And honestly, we all see doctors here, right? The bar is so low to be good. I mean, the average doctor, the face-to-face with a doctor is now 8 minutes. I mean, I can't tell you the last time I saw a patient for 8 minutes. I see the minimum is 30 minutes. So that alone, patients enjoy, just to get to talk and ask questions. So that's how we're going to grow, is to get people to get into this, and then let the people that are coming up and training understand that the work-life balance is there, we're reimbursed fairly, we get them home to see our kids, and things like that.
And we are trying to get them, I've had medical students for 10 years coming through my practice. Michael, and I know Chamonix's had some residents. I'd love to get more residents through. I've had some. I'd love to get a grant. I've applied for one and we didn't get it. We have a nonprofit called the Pennsylvania Direct Primary Care Association to get a grant to pay for the malpractice for residents to moonlight in our offices. Get their feet wet, see what it's like to run a small, that it's not that scary to run a small business. So we get more of these practices, because I have a feeling that there's going to be a point, especially with the cost of healthcare for employers. The Kaiser Family Foundation, all of their data is about employer costs for the healthcare and how it goes up every year, and it's costing more for the employer and more for the employee. There's going to come a tipping point where there's not going to be enough DPC practices. I think we're going to need more of us. And, we can't provide, our panels, like Chamonix said, 400 to 600 to be able to provide the level of care and the time. We could be in there 24 hours a day and have bigger panels, but we'd be, dragging our butts.
In that slide, you saw the numbers and the growth. And even in Pennsylvania, within the Pennsylvania Medical Society, the independent practicing physician section that was just created and is, right now, we are working towards teaching our young learners early, this is what it means. It is really hard, like Michael, that debt that you come in with into the system, it's easy to sign a contract because somebody says they'll pay the debt. But to say, how can I navigate this to keep my autonomy? So that's part of the efforts of our independent section within the medical society.
We need a huge sponsor to give loan forgiveness to doctors who do DPC. Yeah. That would be wonderful, wouldn't it?
Yeah. The other way, just one other way that things are growing, and I prefer the independent ones for sure, but big money is starting to come into this. There's starting to be roll-ups. There's starting to be national firms that actually have the money. I see it more with large employers where they say, if there's a large employer, we'll open an office right there. So I have always enjoyed either through my profession or like I said, what my kids go to. I've preferred the independent ones, but there are big companies with money starting to grow practices around the
The
country.
direct care model.
In the DPC model.
Yep.
Yep.
You want to go first? I guess since everyone's mentioned medical students a couple times, I would have loved to introduce some of the medical students that I had to rotate at a DPC practice. I actually didn't know that there were DPC practices with medical students.
Because they don't offer it.
It's
don't
hard,
offer it.
yeah, it's hard to get, that's the thing. We can't, people don't know we exist, you know?
The only
and,
reason
yeah.
I get the Lehigh Valley students is because I started taking their select students when I still took insurance. And so when I went
Yeah.
without insurance, they kept me on as assistant clinical professor at USF. Now that Jefferson has bought them, my last year of students is starting in June, and Jefferson's not going to continue it. I'm kind of really sad about it.
Yeah, same situation. But I guess then technically there's no restriction, right? Like as long as a medical student wanted to rotate on their own time outside, like for an audition,
For an elective.
It would have to be an elective, yeah.
Actually, I've had some of the DO students do their family practice rotation with me, like from Erie, West Virginia, PCOM, that they've come and done their family practice. Because, PCOM's definitely, that's my alma mater, and they're very familiar with what I'm doing, so.
And the family practice, American family practice, if you look at it, they all promote DPC as an option for primary care. It's huge effort on that, but it's hard because basically everything is medical education and everything is in large health systems because that's where patients are, right? So it's hard to break into that to teach the model. So people coming out know an option.
I can tell you, though, that last year, there were out of the select, I guess there's 50-something select students, there were 17 who requested my office. And they called me and said, how many can you take? I said, send them all. And there were 6. That was the most I had. And then this year also, and I found out that they have to fill out a questionnaire and they have a specific interview in order to come to my office, and I wasn't even included or a part of that. So I guess there were so many requests because you talk about the social determinants of health and all of this other stuff. There's no place you see or you get time to really dive into that than in a 30-minute visit with the patient. So they're learning in my office and they're managing conditions, and it's not all UTIs and sinusitis, and it's not treat and street, So there was demand for them to come, and I almost felt bad that they all couldn't come, even for a day.
What our model offers is it takes literally 30 seconds to write a prescription, but 30 minutes not to. And
That's true.
And that 30 minutes not to usually means there needs to be a follow-up and why and all of that. So
How do you approach
The
the Medicare?
Medicare population, how do we take care of them?
Well, I mean, do they need to have, can we just go with Medicare Part A, not supplemental stuff?
There's no rules for us. Those are government rules. So they come with their Medicare. We've opted out, so we can't bill Medicare. But I can still write, we have a special status called ORP, Ordering, Referring, and Prescribing, for Medicare and Medicaid that allows us to still write prescriptions and order things through a patient's Medicare, and they can still use their Medicare.
Do you recommend the care part?
I can't make those, I'm not an insurance person, we can't make those recommendations. Those are laws.
Yeah.
There's laws with your Social Security, and you have to have, yeah, I know.
You don't need Medicare, you don't need supplement.
But there's Medicare savings plans, MSPs, MSAs, that I don't think have been promoted or taken advantage of there's some kind of, it's kind of like an HSA, and people can use that to pay for the direct primary care. But what I find, I have a lot of Medicare patients. I have a lot of chronically ill patients with a lot of chronic conditions and that are very complicated. They will, one of the benefits is that we dispense medications through the office. So I don't know who grew up in Pennsylvania or in another state where your family doctor used to give you your little envelope with amoxicillin and you'd walk out, with your sore throat. Doctors have been able to dispense in Pennsylvania and 46 other states for a long time. And now that stopped because most of the doctors are employed and they're not they don't set those dispensing situations up in employed offices because everything has to go through the insurance. So we dispense. And we're actually going to promote that all independent doctors in Pennsylvania, no matter what the specialty, should be dispensing because we get the...
Kim's writing a resolution for it.
Yeah, I'm writing a resolution for the House of Delegates for it because we can get the medications at wholesale. I have Medicare patients who buy their medications, their prescriptions through my wholesaler, and it's less than them going to the pharmacy and paying for it, which is incredible to me.
Our self-dispensing is literally less than a copay when patients buy medicines from us and they pay cash pricing. So where is that coverage that insurance has on the medicine? And
the markup.
Markup that's actually there when you go to the store and you say, to the pharmacy and say, I only had to pay my $15 copay to get that prescription.
Well, that bottle of lisinopril, 10 milligrams and 90 tablets is really only $2. $2, 2 cents a pill.
Maybe a question for Chris. You talked about the optional, so if an employer, Dr. Lewis' comment, there's a comfort having a car. So I can see a situation where employees might be reluctant to make a change, but if the change is somehow introduced over time, in order to get around it, becomes something easy. If you have any problem with these structures, we will give people options, one of which is a plan with a DPC. They can decide to do that, or they can just go with a conventional plan. My guess is as the word gets around the house, and people start to recognize and say, I can go to the doctor anytime, let's wait 2 weeks for an appointment. And then people start to say, hey, that sounds pretty good, I might try that next time around. Are there any obstacles to structuring something where, let's say only 5 employees out of a group of 100 decide to do it? Which is a minimum number to make that happen?
That's actually more the question with the DPC office, which I've never come across. The question was if only 5 out of 100. No, from the plans. So especially if you were saying the self-funded option with optional DPC, there's no limitation. There's no minimum from the plan's perspective. The plan has contracted with 1 or more DPC offices that will pay this amount if our employees sign up with you. So what's going on with the plan where I say it's self-insured with an optional DPC? It's a full regular medical plan. It happens to be self-insured. And so the employees have this plan. They can go to primary care physicians and pay the $40 copay. They can go to the regular health system with we'll call it regular insurance. It's simply being offered. You can have that whole plan, and you can go to a DPC and have the DPC paid for. So to a lot of us, that would be like, wow, I mean, why wouldn't you do it? To be honest, the only reason why people don't do it is, especially some of I don't mean to be talking about younger generations. A lot of younger generation, they don't even have they don't go to the primary care. One of the biggest obstacles we have of getting people to sign up for the DPC part that will be paid for them is simply go see a primary care physician.
This younger generation didn't grow up like we did with a family doctor. Again, that's how the specialty, and I'm going to call it a specialty, has been decimated. The value of having a primary care physician is gone. And it got destroyed after the Affordable Care Act was passed. So now, people are, I do have some young patients who do now, who love having, calling me directly and rather than going to urgent care. But I think it's going to be a long road to change that back to that we're the first call. We're the front line. We're the infantry.
A lot of them think urgent care is that call. I mean, fortunately, that's better than them thinking the emergency room is that call, but a lot of them think the urgent care is that call.
Yeah.
Yep.
This is a question over here.
Oh, thank you.
This gentleman had his hand up first. Okay. I think it's important to, rather than, very important is the time of access to a doctor in terms of getting into a doctor sooner. But I think what is understated in this forum, and I think needs to be overstated, is your alignment with specialists and how certain things can be done, particularly those that are focused on deductibles. So those who don't need to really eat away the deductible have more of an advantage to use you as opposed to someone who does need to eat away the deductible and go to an imagery, for example. And so I think that speaking of those contrasts and speaking of the actual costs, I kind of learned this from Dr. Arnett. He's kind of my mentor as it relates to PCP understanding well, but it's important to really speak to how you align with specialists and how you could save money there.
Well, let me ask you this. Why do you have to eat away at your deductible?
Well, those who have other things, that's a good point. That's a point.
Because most people don't meet their deductible.
My education hasn't gone that far yet. So
Okay.
I can educate you. But those who do have to do that have comprehensive healthcare needs where they go to the doctor very regularly, they go to the specialist very regularly.
So they're going to chip away at their deductible.
So they're getting to that point now. Having said that, you did mention earlier that you have patients that you have comprehensive medical needs. So perhaps you can sort of marry up.
So what I do at the beginning of the year, deductibles reset. They come in for their blood work. Did you meet your deductible yet? No. Then we're not going to put your blood work through your insurance because it's going to cost you several $100s. Save that for one of your larger medical needs. 6 blood tests, annual blood work's not less. It's about $100 through my office, so they pay cash. They pay the discount because we get discounted lab fees too. So we talk about that. We talk about their insurance. And some patients would rather pay cash. I had a family with a $30,000 deductible. The father told me nothing gets put through the insurance. Everything is cash. Because it was he had like 5-6 kids. So it was the lowest premium he could get for his large family. But even paying cash all year, he spent less than if he had met the deductible. So that's where I'm talking about, where people are becoming consumers of healthcare. But we have those conversations with them because we understand how the insurance works. It's amazing how many physicians in the system don't understand how the insurance works for the patients.
Please add to my answer the difference between street price and the price being offered. Use imagery as an example of an MRI.
Correct.
Can you illustrate?
I have a patient who needs a CAT scan and is holding off because he's afraid it's going to cost too much out of pocket. And I told him the cash price is $350 for a CAT scan.
As opposed to?
About $2,500 to $3,000. Yeah. It's the.
You're talking well, Dr. Arnett.
Yes. No, it happens. The transparency that we're able to offer our patients with prices, and you just show them, and this is how much it would cost. You decide if you want to pay us or if you want us to order this through your insurance. Patients decide, and what happens. So I, growing up. Not in the mindset of needing to have insurance. When I went and looked at our insurance plan from hospitals, what we were paying, it was about $125 per person per 2-week pay period is what gets deducted, right? So that's $500 a month deducted. But I don't actually feel that $500 was deducted per person because it's deducted and it wasn't in my paycheck. It just goes into the bank account. So because of the lack of it's a lack of being able to actually recognize that. You don't even actually recognize that you're paying all this money for your healthcare costs. So there was a study, I don't have it up or anything, but they did the average healthcare cost for a family of 5 in Pennsylvania, and it ended up being about $20,000 a year was the average family of 5, which is like a mortgage payment for a family of 5. And that is not even including their deductible when you actually take in every 2 weeks how much a family of 5 pays for their insurance. So that whole concept, everything is covered, but nothing is covered, like I didn't realize that, and
then you're paying your copay, you're paying 3 times
Right.
your health insurance, and it's after-tax dollars.
And then every time you go and get a script filled or whatever, you're still paying something, which is more than it would have cost at cash pricing. So it's really just I think the biggest hindrance to changing healthcare, the way that it is delivered, is restoring that relationship and the comfort level of that card. And to say you can, and so what I usually tell our patients is just try it out for a year. If it's not, you have to look at 2 things. Is it benefit to you as a healthcare option, and is it saving you money? If those answers are no, you should not be in our practice. And so take a look at it.
And I have some patients who don't even care about the savings and the money. They just like getting me on the phone at night instead of, pushing 1, 2, and 3 or ending up in urgent care because they can't get anybody on the phone. They just want their own doctor. So the savings is very important, but there are people out there who want that relationship with their doctor.
And the movement is growing. Like, the doctors are wanting to do this. I have talked to probably about 7 doctors within this year, 2025, that are thinking about how to do this model. So they're,
So we're going to also get the Medical Society to start a curriculum on how to run a small business.
Yes. And the Medical Society, the independent section, is like totally robust.
Going back to
Yeah.
this whole economy of the hospitals versus the DPCs, because it seems like the hospitals could and should be
Embracing this. Yes.
and encouraging
Yes.
sending their
Thank you, buddy.
primary care, physicians and internists
Yep.
to collaborate with you, because they can't any longer provide a cost-effective delivery.
No, I know primary care drains the hospital. Their cost. Yep.
Can, and they all complain about how they have to open all these urgent cares because they don't want people coming to the emergency departments, and they certainly don't want them coming to the emergency department, so go there, but even the emergent care
They're not.
facilities can't do.
They don't take care of
They don't
anything.
take good care, and we see them in our
All
office
the time.
afterwards.
Yeah.
And to what you just mentioned, to me, yeah, there's a cost factor here, but that access, your, modeling, your logo, your AAA, those, you can't put a price on them. That's like the ultimate bottom line.
Right.
And those that can, should take advantage of it, and then they can figure out what to wrap, even if they're paying a full freight receipt, tens of thousands of dollars for the catastrophic, hospitalization and super specialty and stuff like that. It just is a little mind-boggling that there isn't a more collaborative mindset.
Now,
Totally.
I have to say, St. Luke's and Lehigh Valley, I'm my own physician liaison rep for each hospital system who have been very supportive. I have access to Epic Link remotely so I can get my patients' reports. So they have been supportive that way, and I'm thankful for that. But I think there could be more done, absolutely.
The whole reason there's urgent care centers, in my mind, is because of lack of access. So the success of this model would decrease urgent cares in a community.
And the medical students are not choosing primary care because they know that it's a hamster wheel, And they have to see a patient every 10 minutes, and of course, it's the lowest paying specialty, and they come out in debt hundreds of thousands of dollars. That's right. That's right. I would love to see a rural, like they do for rural medicine or underserved areas. I would love to see some kind of incentive coming from somewhere. And again, I hate to get the government involved because they always mess everything up. But some kind of incentive to do some loan forgiveness, it would be a shot in the arm for primary care, and that's what we need.
All right, we got one question yet here.
I think it's interesting that earlier this year, a healthcare CEO was murdered in broad daylight in New York. A lot of people in this country love that kid was a hero because they don't like the healthcare system in this country that much. So I love the idea that Buddy talks about the hospitals partnering, but I kind of feel like maybe they're like the anti-hero in the situation. And I'd love your feedback. Are the hospitals the bad actors? Are the pharmaceutical companies?
I think they're all complicit. Sorry, Betty.
You could call them a cartel altogether.
Yeah, we call it the medical cartel, the medical industrial complex. They're all complicit. Now, they want primary care offices because we feed the specialists and we feed the testing. We're still going to feed that. We're just not owned by the hospital. Those referrals aren't going to go away, and those prescriptions for x-rays and blood work, they're not going to go away. We're still going to send them somewhere.
And it's not there's like the hospitals are bad, pharmaceuticals are bad, or I don't think it's any one entity is bad. Even insurance, I don't think insurance has a place and a purpose in healthcare. It's not that it's bad. But what happens is our healthcare model is what we call vertically integrated, meaning that like CVS Health, the parent corporation that trades in the New York Stock Exchange, they own the providers, they own the health insurance plan, they own the benefit managers, they own the pharmacy,
yeah.
They own all of that.
Talk about a conflict of interest.
Right, so when you control the market, it's really the separation of those entities, and that's what we need our government to do, is to actually pass the rules that prevent that separation. Even Medicare Advantage, I call it not an advantage because it's really private insurance. So it has the perception of being an advantage, but it's not. Because it really is in that market. So we have to separate, and then that's when we could collaborate.
And there's been a lot of money made by third parties, and it's going to be hard to take that lollipop away. So, once the FTC and the DOJ starts looking into some of these things, which they are starting to do finally, Medicare Advantage is being investigated for some kickbacks. It's going to be peeling an onion back. It's going to take a while. But in the meantime, we're losing physicians and we're not taking care of our patients.
But they're legalized kickbacks.
They're legalized kickbacks.
They're legalized kickbacks.
But the bottom line is we still have a job to do. We went to medical school to take care of patients, and physicians are retiring early. Suicide rates was high before the pandemic. And then you have the pandemic thing. Actually, direct primary care thrived during the pandemic because we were able to shift and pivot, whereas the other offices were told to close that were, employed. I was drawing blood in the parking lot and taking blood pressures through the window because people were afraid to come into the office in full PPE. But we were able to take care of our patients. So that's what we still have to do. And we're weathering the storm. And hopefully, this is the beginning of a change.
Yeah, there's an independent group of primary care doctors in Central PA who actually bought a bus during the pandemic and went around and took care of patients. So I think doctors at the heart wants to take care of patients. We just need to be able to do it.
All right. Yes, go ahead.
Sure.
Yeah, that'd be great.
Yep. There's lots of studies too. If you Google, now that the model has been around for a while, there's a lot of data out there on the employer. Yep. Yeah, and then that, if you go to those sources, there's even more that you'll find underneath that.
All right. Very good. Well, thank you, Dr. Wheeler, Dr. Korba, and Mr. Van Buren for a fantastic program. Let's all give them I know I learned something about direct primary care, and I hope everybody else did too, and it's really an interesting field, so absolutely. And we want to again thank our sponsors, Lesavoy Butts and Sites and Russ Law LLC, so thank you for sponsoring this. And sure, everybody, our panelists are going to stick around after this, and the bar's open. We got some hors d'oeuvres in the back, so please help yourselves. Stick around for some networking, and we'll see you at the next LVPCO event. Thank you.